Okie dokie. So today's plan, just like everything else, I always have a plan for you. So we already checked off quiz 1, and now we're going to discuss chapter 4. Prenatal care is very important. Prenatal care, it starts, when you are pregnant or before preconception planning is the best. But when you get pregnant, you have a little fetus inside. And whatever you take in, the mother takes in, will benefit or do harm to the fetus. So keep that in mind as we progress during these slides. Now, this is important. This is how pregnancy is divided. All right, so the beginning is called antepartum, and you will hear me say antepartum, or intrapartum means during the birth, intrapartum. And then your postpartum is after birth, it's the recovery time. So I always said my focus on prenatal care is to teach mom how to maintain good health and improve her health. Maybe she doesn't have the best, eating habits. She's going to get better because nurses, we want to prevent something from happening. We know that if mom doesn't take in the adequate amount of nutrients, the fetus is going to feel it. So again, whatever mom takes in. So write this down. Healthy mom equals healthy baby. Okay. Always keep that in mind. Now, we do have a team. Remember, it takes, they always say it takes a team to create a village. Well, here it does. We have obstetricians, we have family practice physicians, we have certified nurse midwives, and we have nurse practitioners. Now, we also have another specialty that works along with obstetricians, and it's called perinatologists. They take care of the really high-risk pregnancies. They're called perinatologists. We all work together. So these are your major goals of prenatal care. So would this be a really good, maybe all that apply question? Absolutely. So your major goals are, I want to make sure I have a safe birth for both mom and child. Okay, that's it. That's from the beginning, when she walks in your clinic, till when we get to labor and delivery, she walks into L&D, to that birth. Okay, it goes all together. Because why? We want to reduce risk factors, guys. Like, say she comes in with chronic hypertension. She's already got a problem, right? This is chronic. So we're going to sit down with her and get a really good obstetrical and surgical and medical history on this patient. Because I know that pregnancy puts a great impact on the health, on her health. So if I know it could be a great impact, don't I want to make sure that I give her whatever she needs to combat that problem? Okay. I'm also going to teach her some health habits that she can take with her and continue after pregnancy, like healthy eating. I'm thinking of the special group of adolescents. Do they come in with healthy habits? No, they do not. Do I want to educate them in self-care? Yes. Do I want to educate every woman in self-care? Yes. I want to provide physical care, and I want to prepare the parents for responsibility of parenthood. Absolutely. Not everybody is ready to be a parent, correct? Right? You can answer me, you don't have to worry. Yes, not everybody's ready. Don't you have to take special classes to drive a car? Do you have to go to special classes to have a baby? Or to be a parent? No. Okay. And then you want to develop a partnership. These are your major goals of prenatal care. The reason why I want to be in partnership with my family, the parents, the family, is to ensure I'm going to get everybody. Okay. When you're talking about maternity nursing, you're talking about the entire family. Okay. That means there's maybe grandparents involved. There's other siblings, could be. This may not be her first baby, may have other children. Okay. And it may not be her first marriage. You have all kinds of situation that comes in to the L&D, into the obstetrical OB. Okay, so now these are some terms that you need to know. So gravida, we talk about gravida, we're talking about pregnancy. Okay, so like if I say she's a gravida of 5, what does that mean to you? She's had five pregnancies. Okay, a no gravida is someone no means she's never been pregnant. So gravida again means pregnancy. No gravida means she's never been pregnant. A prima gravida means she's been pregnant. What? It's her first pregnancy. She's a prima gravida. Multigravida means she's had, she's been pregnant for at least a second time. So again, gravida means pregnancy. All right. Now, the para means the number of pregnancies 20 weeks or greater. So if I say she's a gravida 1, para 0, what does that mean? That means she's having her first baby and she doesn't have any living children. So this is how we get an obstetrical history. So we can do a 5-digit or we can do a 2-digit history. So I'm going to go over both so that you understand, because this is really important to know the gravida and para. Okay, it will be on quiz 2, and it will be on exam number 1, and it will be on HESI. All right, and then we go to like gestational age. That's how far along the pregnancy is. Remember, gestation is another term, is a term for pregnancy. So if I say she's 24 weeks gestation, what does that mean to you? Come on. She's in her
24 weeks into the pregnancy.
Yes, she's in her 24th week of pregnancy. And fertilization age is the time that was from the fertilization. Where does fertilization occur?
Fallopian tube.
Yes, fallopian tube. Good. Now, the age of viability is what? How many weeks is the age of viability?
20.
20 weeks, right. Okay, good. And those are terms that are very important to know. So here is my 5-digit. So when a person comes into your clinic and she's, comes in and says, hello, my name is Mrs. Jones. I think I'm pregnant. Okay. So you want to know her obstetrical history. Is this Mrs. Jones' first pregnancy or is this her 5th pregnancy? Because based on how many babies she's had really impacts your care. Okay. So I want to know her GTPAL. I want to know how many pregnancies she's had. That's her gravida. I also want to know, I'm going to dive in a little bit more now than just the 2-digit. I want to know how many term babies this woman's had. Okay. It does impact her care because if she had a lot of pretermers, What's the odds of her having another pretermer? It's pretty high. So that's so important to know. So this is Mrs. Jones. And Mrs. Jones, this is her. Let's see. Let's make her. Well, how many babies you want her to have? All right. Say she's on her 4th baby. This is her 4th pregnancy. All right. So she's gravid of 4. How many term babies did she have? Oh, let me see. I had 2 term babies. Okay. That means her babies were from anywhere from 37 weeks gestation to 40 weeks gestation. Okay. Mrs. Jones, how many pretermers? Let's see, I had 1. Okay. She had 1. That means she had a baby born from anywhere from 24 weeks to when? To about 36, 6, 7. Or it could be from 20 weeks because 20 weeks is viability. Okay. And then abortions and miscarriages is anything that's below 20 weeks gestation. Okay. All right. And abortions and miscarriages go in the same category. Well, believe me, I've had a lot of women that got very upset. I didn't have an abortion. I had a miscarriage. I understand, but that's where we put them. Okay. And then how many live births, Mrs. Jones, did you have? And she says, oh, I have 3. So then she has 3 live births. Okay. That's how you do it. So when you're on a test, you want to write down on your little scrap paper, GTPAL, so that when you're reading the scenario, now listen up, when you're reading the scenario, you're reading and you can plug in your numbers. That's my suggestion to you, okay? Don't forget the present pregnancy. Now, I say that with a little more emphasis because that's what students forget. They forget the woman is, the reason why you're doing this obstetrical history is because she's coming in because she's pregnant. So don't forget the present pregnancy. Okay. So here, I just did this with you, so we'll just skip it. But anyway, it's a woman that's pregnant for the 4th time, and she's had 1 elective abortion during the 1st trimester. So that means she was less than 20 weeks. So that goes on to the A. The daughter was born at 40 weeks. That would go on to term, for T for term. And the son was born at 36 weeks. So he would be what? Preemie or a P. Okay. So that's how you figure out your GTPAL. Okay. Now, the next thing you have to remember is that pregnancy is divided into 3 13-week parts. So when you say the 1st trimester, you're saying from week 1 to week 13, the end of week 13, 13 and 6/7. That's how we write it. And so that during that time is a very challenging time for a woman because, she's not feeling so good. So usually I tell them, you'll come out of that around in your 2nd trimester around week 14. 14 gets better as the weeks go on. So remember, it's 3 13-week parts. And we have to know, because each little segment, and your book puts a really nice how the trimesters are. And we have to know what's going on in each trimester because there's certain things that happen as the baby grows. Okay, baby's needing more things from mom. Mom has to get maybe her ROGAM, maybe she has to get an amniocentesis. Things happen during the pregnancy during certain trimester times. Okay, so that's why we do that, and we see a development of what we call pattern of development, how the baby's developing inside mom. Okay. Now, ideally, guys, prenatal care should begin when? Before she even thinks about getting pregnant, preconception. Do a lot of people do that? No, I see a lot of people shaking their heads. No, they don't. Where you see that most often is the older couple. Okay, maybe they've had their career and they're saying, okay, my clock is really ticking, so I think I need to get into an obstetrical clinic office so I get some prenatal care started. Now write this down. It's so important to get this started. The folic acid and the prenatal vitamins, the best time is before conception. As you went over the embryonic milestones, and so how the embryo develops in the first the first 6 weeks, you can see that you need to get that good nutrition in, so that the endometrium, it has a lot of good, rich blood supply that makes sense. So that's why it's wonderful that they come in before conception. Doesn't happen. So whatever she comes in, as long as I always opt out for prenatal visits, I'm just happy when they come. Now, some women come in and they're coming right in at 10 weeks. Okay. But they've already been on taking the prenatal vitamins. Great. Some come in later. As long as you come in, we can start doing what we need to do to protect mom and to make sure she's healthy and make sure the fetus is healthy. Okay. Now, we always looking for risk factors. Nurses, we always are thinking prevention, okay? Because maternity is a form of prevention. We want to prevent bad things from happening, because what happens to mom can affect the fetus. So I want to identify these risk factors. I want to make sure she's eating well. I put that in red because it's really important to know this. And we want to make sure she's taking folic acid, because we had a lot of research done on this area, and knowing that she takes like 400 micrograms per day in the beginning, and it will increase, is wonderful for the closure of that neural tube. And you saw on that little embryo from last week how the neural tube goes right down the spine. And if mom is not healthy, maybe mom's smoking, taking drugs, she's not healthy, she's not taking any folic acid, she's not even taking prenatal vitamins, she's thinking of when she can get her next drugs, she has the greatest chances of that poor baby born with his meninges outside his body. And that would be spina bifida. And hydrocephalus is also another neural tube defect that's in the brain. Okay, so these are very important things that can happen. And by nurses, we don't want that to happen. We don't want any of that to happen. So what is my role as a nurse being in this prenatal care? Well, I'm going to be very diligent on my complete history and physical. Absolutely. I'm doing an obstetrical history, my GTPAL or my gravid and para. I got to know, is this her first baby or her 7th baby or her 10th baby? I've had gravid 11s come in, and their cervix, let me tell you, their cervix is real soft. It's because it's been open so many times that the cervix didn't come back and close up real tight. Is she at risk for a premature baby? Yes, she is, because the cervix needs to be closed. Okay, so that's why it's important to do that obstetrical history. I'm also going to find out about how healthy she is and what kind of a diet she's following, and get her on the vitamins. And also in the very beginning, that first visit, we'll do, if it's about 10 weeks, 8 to 10 weeks, we could do an ultrasound. Now, ultrasounds are done in the beginning, early, to get the measurement of the baby. So what we're looking at, because he's so tiny, at 8 weeks, that we do a crown rump measurement. That's the top of the head to his little rump bottom. It's crown rump. Write that down. Crown rump measurement on the early ultrasound. Now, by doing that, I can determine how many weeks gestation she is to make sure. And number two, I can figure out her EDC because we have a measurement scale right on the ultrasound that if I'm measuring so many little centimeters or millimeters, I can measure that right up and find out exactly what her due date is. Now that's pretty good. Now also, let me throw this in here. That first ultrasound is so important because we want to see the heartbeat. I mentioned this last week, but I'm going to mention it again because it's one of the complications. If you don't see a heartbeat in the very beginning, you don't have a viable fetus. You may have a cluster of cells, and that's called a molar pregnancy, M-O-L-A-R, molar pregnancy. Or another term that you might see is hydiniform mold. Okay? These are, it's where it's just a bunch of cells that just kept cell dividing because the cells don't know any better. They just keep growing, you know, they don't know there's no heartbeat. So what happened, it just didn't form. And basically, it's not a baby. Now that's why we do those ultrasounds at the very beginning, because we want to make sure that there is a heartbeat. Okay.
If there's not, and it keeps growing, what happens?
Okay, so what happens is that one, her uterus will become very large. If she doesn't come into the clinic, usually their stomachs get very big because they're producing all these cells and they just keep multiplying. It's just like a bunch of grapes. That's what it looks like. And what happens is that this just keeps growing. So, and your HCG levels, that human gonadotropic hormone, goes sky high. It just goes sky high. So she usually, if comes into the clinic saying, I don't know what's wrong. My belly is quite big. What's going on? And we do an ultrasound and we find that she's pregnant, but we found no heartbeat and we just see cells. Yeah. So what happens is that she has to have a DNC. We have to evacuate the entire uterus because those cells, remember the blastocyst, it made its way into the uterus, just kept dividing, didn't know any better. So it kept dividing, got bigger and bigger and bigger. HCG levels go up. Her uterus should be not way high in her abdomen. It should be, you know, at 10 weeks, it's just coming out of the pelvis. And now it's like halfway up to the umbilicus. That's not normal. That's an indication that there's something wrong. So we do a DNC, we evacuate everything out, and then we have to, she cannot get pregnant for 1 year, okay? Because she has to have multiple or repetitive, I should, you know, lab tests to make sure that the HCG levels, go down, okay? So we find that it takes that long for those HCGs to go back to a more normal state, all right? Like nothing. It has to go back down to zero because when you're not pregnant, you're not secreting that hormone. Now, it's very important that now later on in life, she has to be watched also because a hydiniform mole or molar pregnancy is one of those precursors to ovarian cancer. Okay. All right, we just got the lecture on molar pregnancy. All right. So again, we already went over this, but this is your role as your nurse, as being a nurse there. So looking at the risk factors, thinking ahead, critically thinking, okay? Nutrition. Now, what group do you think would need more nutrition counseling than any other group? Think of your adolescent. They need a good nutrition counseling, right? Okay. You have to watch your diabetics, okay? We have cardiac patients that come in, they're pregnant, okay? All those we have to be very careful with, okay? And then again, too, we're promoting family adaptation to pregnancy. Everybody changes once you're pregnant. Now, is everybody happy in the beginning? No, there's a lot of what we call ambivalence in the beginning, okay? And I think that's on exam 1. Ambivalence. Ambivalence, it means that, I don't really know. Am I happy? Am I sad? What am I going to do? Oh my gosh, I had a career. No, I went to do, all that comes into play. Okay, that's normal. That's almost be expected, especially if you're not planning. People, women that are in school, say they're going to college, and all of a sudden they didn't have their period, and they did a home pregnancy test, and that that HCG level is there, and positive pregnancy tests, right? Okay, so those cause ambivalence, okay? But she gets over it. She adapts to things. That's what this chapter is all about, the woman adapting to the pregnancy. I already went over all this already, talk about the obstetrical history and the last normal period, okay? A lot of times you'll see LMP, last menstrual period. Okay, everybody's probably very familiar with that, especially our ladies in the class. But I also want to know if that's a normal period, okay? Because some women sometimes they have extra periods, but last normal period. Okay. Again, we're looking at her woman's health. I'm looking at her weight. I'm looking at her vital signs. I'm looking at blood pressure. So when you come into a clinic or an office, okay, you're going to get a good history, but I'm also going to do a weight and a height, and I'm also going to get a urine sample. And I'm going to make sure that she doesn't have any beginnings of a UTI. Okay, so because that would also cause her bladder to be inflamed and cause the uterus to contract, and therefore she could have a miscarriage in the beginning because it related to just a UTI. So I'm going to get that. I always want to get a baseline in nursing, no matter what field you're in. You always want to get your baseline vital signs, because then you can judge. Okay, you can judge if the next visit she comes in, if she has an increase in blood pressure, you want to see if there's going to be a pattern going on. Remember the 30-15 rule. So you always want to make sure that you get a baseline vital sign. That first visit, we want to figure out when she's due, okay? Her due date. So we got a couple ways. One I told you about, the ultrasound, and the next one I'm going to be talking about pretty soon here is called Nagel's rule. Well, let's see what that is here. Okay, I'm not up to that yet, but just write that down. All right, so this is a schedule of visits, prenatal visits. Okay, in the beginning, from conception to about 28 weeks, she comes in every 4 weeks. Now you think that's not bad. I mean, every 4 weeks, right? It's not bad. Now if she's high risk, it's going to be much sooner. We're not going to be every 4 weeks. But right now we're talking about normal pregnancy. So about every 4 weeks. And some women, I tell you, complain that they have to come in. Believe me. Okay. But we want to see the progression and make sure that her blood pressure, she's free of UTI, she's eating, and the baby's growing. Now, 29 to 36 weeks is every 2 to 3 weeks, based on what's going on with her. If she's showing some signs of increased blood pressure, she'll be every 2 weeks. Okay. If she's okay, if she's normal, she's doing good, be every 3 weeks. Okay. Again, you're like emphasizing, I'll see you in a couple of weeks. I'll see you in 3 weeks. Okay. Now, from 37 weeks to birth, they're coming in weekly. A lot can happen. Now, we're getting close to our term. We're getting closer. We want to check, make sure she's not, what's going on. Baby's moving, baby kicking. Maybe you have to do NST, which is NST is a non-stress test. that we look for fetal movement and acceleration of the baby's heartbeat. I want to make sure that baby's okay. So that's why I'm going to have her come in. A safety alert. Remember, nurses, we look at safety, big time. Prevention, safety. So again, early and regular prenatal care is important for what? I want to reduce the number of low birth weight babies. I want to reduce morbidity, mortality for both moms and newborns. I want to pick up on things. I want to pick up things that are early. I don't want her to come in and all of a sudden she's having, she has hypertension, she's having blurred vision, she's seeing spots before her eyes, she's gaining a lot of weight. I got preeclampsia. Preeclampsia is very severe complication during pregnancy, which occurs after 20 weeks gestation. So I've got to be on top of that. I've got to be testing her urine every week. I'm looking not only for nitrites and WBCs, I'm looking for protein. I'm looking for glucose. Got to make sure the kidneys are functioning. Okay. So that's why it's so important to see this woman on a regular basis. I want to make sure I do a fundal height. I want to make sure that the baby's growing according to week gestation. If you have a lady that's 26 weeks gestation, she should measure on her fundal height 26 centimeters. Okay, and I'll show you how to do that in just a minute. All right. So this is your antepartum nursing care. Again, good slide. It kind of just summarizes everything we talked about. And I'll go over Nagel's rule in just a minute. Okay. Now, this is, I'm going to tell you, heads up on this. I got it highlighted for you. It's for a reason. Yes, you will see this again. It's a great all that apply question. Is what kind of blood testing would you see when they first come in for antepartum nursing care? Now, we're going to do HIV. We're going to do a CBC, complete blood count. I want to know her rubella titer. I want to know if hepatitis B. RPR is testing for syphilis. A VDRL is your venereal disease research lab. Again, I'm looking for STIs. Okay. RH, write that down. I need to know her blood type. Is she B positive or is she B negative? Okay. Because remember, a negative doesn't mix well with positive. So if she's negative, then she will need Rogaine during her pregnancy. And I think I talked about that last week, but now it's coming into play. You have RH. So I want to know her blood type. That's what I'm getting at. I want to know her pap smear. Does she have any cervical dysplasia? Anything abnormal on the cervix? Okay, because we need to take care of it. I'm going to do vaginal cultures like gonorrhea, syphilis. How about chlamydia? Yeah, I'm going to do chlamydia. Now, if she's sickle cell, I may do a hemoglobin electrophoresis just to see where we are. And of course, the urinalysis. I'm going to, a lot of times we use that hemoglobin hematocrit because we can determine if she's having a healthy diet, she's eating well. So we do a little blood test. When she comes in, we can do a little finger stick because anemia is a problem during pregnancy. Okay, and a lot of women do get anemic during pregnancy because the heart, the cardiovascular system increases by 45%. There's a lot more cardiac output. So yes, of these vital organs, her vital organs are going to take some hits. So we need to make sure that she's doing what she's supposed to be doing. Because if she's anemic, then I got to give her an iron supplement, okay? Because it's just as the pregnancy gets more, the fetus is going to take more, and so her body will really be depleted. I don't want that to happen. So I'm going to tell her to take an iron supplement. Now, let me tell you, it's not so easy during pregnancy to get these women to take iron supplements. It is because during pregnancy, the problem with during pregnancy is constipation. So, You know, if you're constipated, are you really going to take an iron supplement? Because, you know, one of the complications with taking iron is what? Constipation. Okay. And then foods that are recommended, you know, that you can have fish and red meats, but nothing that is on a fish, nothing that is an bottom feeder. You don't want her to have that because it has mercury. So you want to keep away from that. Yellow, how about green leafy vegetables? Okay, that's good. How about fruits and, you know, egg yolks and dry fruits, all those good things that people don't eat. I want her to be good nutrition wise. Okay, so at each prenatal visit, this is what we're looking for, her risk factors. Okay, review them, know them, review them. How you doing, Mrs. Jones? Evaluate weight gain, blood pressure. We talked about this already. Urinalysis, blood work. I'm checking for anemia. Fundal height. On the fundal height, not only am I looking at fetal growth, but do I have enough amniotic fluid volume? If I'm thinking, if she's not measuring correctly, like if she's supposed to be 26 weeks and she's measuring like 23 centimeters, that's not correlating correctly. So is it the baby or is it the amount of amniotic fluid? Because since amniotic fluid is generated by the fetus of his urine output, we have to worry about the kidneys of the fetus. So I'm going to do an ultrasound. If I find that that's not, the fundal height is not agreeing with the gestational age, I'm going to do an ultrasound to see what's going on. All right, Leber-Nose maneuver is a way that we check for presentation. And when we get to that chapter and when we get to labor, I'll go over that a little bit more. But I just can take my hands and I can see if his head, if the fetus is head down, which is cephalic, okay, which it would be nice and hard down there, okay, and soft up here, that would be his buttocks, okay. By doing that, I can determine how he's presented inside. Now, write this down. The fetal heart rate is normal between 110 to 160 beats per minute. You're going to need to know that. So 110 to 160, that's normal. So if I say anything that's below 110, if I say like 100, 105, that would be bradycardia, okay? Anything that's above 160, okay, 160, that would be tachycardia. So like 170, 180. You know, mom has a temperature, say. She comes in and you take her temperature and she's quite warm, maybe 101. It's very common that the fetus then would be tachycardic. That's one of the reasons we see it. If she's abrupting, we'll see that too. So it's all according to what's going on with mom is going to affect the fetus. Okay. All right. And then, of course, we get back down to nutrition. Okay. Because especially during the third trimester, that's that last go around, that last 13 weeks, right? That's when the fetus is really growing. He's getting all his brown fat on him, and he's really getting big inside. Because mom needs to eat well in order for baby to look good. Okay. All right. All right. So I would know the normal increase should be about 300 calories with mom during pregnancy. It's 500 calories during lactation, which is breastfeeding, but 300 calories should be an increase of her diet. Okay. So you're going to get a good diet history. You're going to see where the deficits are in her diet, do your recommendations, and then also make sure she gets an extra 300 calories. Okay. Now, those calories should not be what we call empty calories, you know, like potato chips, all the, you know, really good stuff that people like, but have no nutritional value. The calories should be nutrition. So I'm going to increase protein about 30 grams per day, increase my iron, like green leafy vegetables, legumes. Okay, those are all good. Make sure she gets enough folic acid. And then increase maybe her intake of vitamin A, vitamin C, calcium. That's important because I have seen where women have lost their teeth because they didn't take in enough calcium during pregnancy. And what happens is that they get dental problems. And then, of course, 8 to 10 glasses of fluid per day. And about 4 to 6 should be good, should be water. All right, so if I ask you this question, a woman is coming in for her prenatal visit and is determined that she's 8 weeks pregnant. Okay, well, we got a pregnancy. So which tests are typically performed at the first prenatal visit in a low-risk pregnancy? Select all that apply. Who wants to tell me
HIV
the
testing.
answer? So it would be what?
HIV testing.
Okay, HIV. Okay, okay. What's the next one?
A, B, D, and E.
You got it. You got it. Now, the glucose tolerance test would be given about week 25 in there, okay? But not at the first visit, okay? So you may see how that question was asked. You have to read the whole thing. In the maternity, for testing wise, you have to really read the scenarios because this is your clue. First prenatal visit, okay, 8 weeks pregnant and a low risk pregnancy. Okay, because say she was a type 1 diabetic. Well, first of all, that would be a high risk pregnancy. So, but and what kind of patient, if she's a high risk, then there would be other tests that we would do in the beginning. And with a type 1 diabetic, I really want to know what's going on in the very beginning. So, okay, I don't want to confuse you though. All right. Also, I want to make sure that the uterus is good, she's free of infections, and also I want to make sure that vagina is free of infections because this bacterial vaginosis is very common. And what happens, I told you last week, is that bacteria ascends in a womb. It goes up. So we don't want it to go up. If she's got anything in that vagina, such as chlamydia, we want to get rid of it. If she's got bacterial vaginosis, we want to get rid of it. That would be bacterial vaginosis is a white milky discharge, okay? And can be associated with preterm labor. So I don't want this. Main thing you remember is that every pregnant woman, I don't want her to go into labor. I don't want them in preterm labor. I don't want to have a preterm baby. No. I want to have a term baby. Keep that in mind. Okay, so here we're going to go. So this is determining estimated day of delivery. So remember I talked about average pregnancy is usually about 40 weeks gestation. Okay. So after you're figuring, you want to figure up when she's due. All right, so you take her last normal menstrual period, okay? Remember, plus or minus 2 weeks, but her last normal. So say LMP. And I want to figure out when she's going to have this baby. Nagel's rule is a way to determine this. So what you do is that you take, now listen up, Charlie, listen up. You take that first day of the last menstrual period and you count back 3 months, and then you add 7 days to that first day of that last menstrual period, and you'll find her due date. Okay, and then you update the year if it deems necessary. So again, the first day. Now, a lot of students miss this question on a test is because they put distractors in there. They may put the first day and then the last day, and some students do the last day. I'm telling you very specifically, so you don't get this wrong, is the first day of the last menstrual period. And you count back 3 months, boom, 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 add the 7 days to that first day, and you got her due date. Okay, so let's maybe do a question here. Okay. I put this slide in here because a lot of students had a lot of problems with this. So I wrote this to let you know how to calculate it. Okay. Let's see here. Here's a brain teaser. I just love Mr. Brain here. I hope you do too. So you want to determine your EDD by using Nagel's rule for a woman whose LMP, last menstrual period, began on January the 7th and ended on January the 12th. So according to what we just learned, when would she be due? So January.
Is it the 14th of October?
October 14th.
Okay. Yes. See how easy that was? Did everybody see that? So you count, you got January the 7th. Don't see, I told you that ended on, I see it on a lot of tests and HESI and everything else. So you don't want, you want a first day. So they don't say first here, they just said began, right? Okay. And so here, January the 7th. So I'm going to keep that in mind. So I'm going to go December, right? November, October, correct? Okay. Add 7 days to January the 7th, right? To the 7th, and I got 14. So she's due October 14th. Okay. So say are you on a test and maybe you're a little bit, anxious on the test, you can write down your scrap paper, the months, that you go back 3. Okay. All right. How about we do another one? So a woman's LMP began on May 4th. Okay, don't look at the years because I've been doing this for a while. So May 4th. Using Nagel's rule, which day would be correct to estimate her delivery date? So May 4th, right? We use May 4th. Okay, so what's the months? So we go back. So we got what? April, March,
February 11th.
February. Okay. And you add 7 days to the 4. So what day would we be? What day would it be?
11.
Okay. So it'll be February the 11th, right? Because you're adding 7 days to this. And being that it's May, you're gonna what? You're gonna go into the next year. Okay. All right. Okay. That's using Nagel's rule. All right. There's a lot of information coming at you today. Very important information. Does everybody have the understanding of Nagel's rule? Anybody? Okay, I'm going to proceed then. I'm going to presume that you're okay with Nagel's rule. It will be on quiz number 2 and exam number 1. All right. Now, when we talk about pregnancy, we have different signs, okay? So we have these signs and they've been grouped into 3 different groups, okay? So when I talk about presumptive signs, that means like amenorrhea, nausea, breast tenderness, urinary frequency, quickening, changes in the skin. Who's feeling that? Who's
The
feeling it?
person who's pregnant.
Right, right. So that's really, see with the U, I put that U, you're feeling it. The person's feeling it. Good, got it. Probable signs. The Cudell sign, the Chadwick sign, the Hager sign, McDonald sign. Who can see those signs? These are signs like the Chadwick is a sign that you see, the examiner, the practitioner, when they put the speculum in the vagina, we look up and we see the bluishness of the cervix is the examiner who sees it. These are signs that practitioners see, okay? How about the positive sign? A positive sign is when you do an ultrasound. That's pretty positive. She's pregnant, okay? You can hear when you do it, you put a Doppler on her, you can hear the fetal heart tones. That's pretty positive, okay? So these are signs that we know. Now, presumptive means also that there could be other reasons why she maybe didn't get a period. You know, there could be a problem with the pituitary. There could be, you know, she's very athletic. You know, maybe she's under stress. She's not pregnant. Nausea could be something causing nausea. So you see the urinary frequency. She could have a UTI. Okay, these are signs that are other than just pregnancy. Okay. And the woman feels those. Now, when you get to the Cudell sign, the Chadwick sign, those are pretty good signs, but they're probable. Okay, just maybe something else could be interfering with this. Maybe the softening of the lower segment is related to another problem that she's experiencing. But that's why it goes under probable. Probable means it's a good indication that maybe she is, but there's always a little bit, is she? Okay. Now, a positive sign is pretty obvious that she's pregnant. Okay. Like I was called down to the ER one time, or many times, so this time, I had a young lady, an adolescent who was pregnant and who was in a lot of discomfort. They were working her up in the ER for like appendicitis. And because you know, you ask them, you know, could you be pregnant? And she goes, oh no. Okay. All right. So all of a sudden now I'm called and I run down there with my my preceptress kit, delivery pack, and she's yelling, I'm not pregnant. Okay. I'm not pregnant. But meanwhile, I'm about to deliver a baby. Okay. And you know, she was yelling the whole time that she wasn't pregnant. But was that a positive sign when I see a baby's head? I had a lot of hair. And I was about to deliver. I said, honey, that's okay. I understand, you know, but right now I just need you to push. And we'll talk about all this after the baby comes out. But right now I need you to breathe. I need you to push so I can deliver this baby. Now that was a pretty positive sign, was it not? Yeah. Okay. All right. Okay. All right. Time is about 4:25. I'm going to give you a 10-minute break right now. I think this is a lot of information coming at you, and I don't want to have you go to sleep on me. So, and I want some interaction, okay, when you come back. So I'm going to give you a 10-minute break. So the time I have is 4:25. So be back in 10 minutes, folks. That means it's what? 4:35. Stay on Zoom. Don't come off Zoom because your attendance comes from the Zoom report. Okay. Have a little break. All right, but we're waiting for everybody to come. Does anybody have any questions about what we have discussed so far?
I don't. There is a question that Alex asked in the chat though.
Oh,
Yes, I did. It was about hang on, let me look.
you
Oh,
want to
the
know about,
GTPAL.
you know,
So what about the mothers who carry past full term and like had to be induced? Wouldn't you want to know that as well?
well, it would fall under term. So if she's post-term, you would put that under there because she's not premature. And then I would ask, then you can ask more questions about how many weeks she went to. And she says, oh, I went to 42 weeks and I had to be induced. Okay. We would take note to that. So that would go under term because she's still term. Even though she's post-term, she's still going to be term. Okay.
Thank you.
You're welcome. Sure. I tell you the truth, anybody gets to 42 weeks, I get very nervous. I've seen babies that didn't survive because mom decided to keep going. We do non-stress tests on those babies and determine how they're doing by the non-stress tests. And but you know, as you get past 40 weeks and go into 41 and you're heading into 42, the placenta gets old. The due date is gone and we've gone past it. And placenta says, you know, I'm a temporary endocrine organ and my time is up. It starts to calcify. When that starts to calcify, it doesn't give the oxygen and nutrients that it should to the baby anymore. So the baby gets less. And babies can die because it gets too old. They're not getting enough oxygen. I have seen that happen. I'm gonna be honest with you. I had a VBAC, and that's a vaginal birth. That's a cesarean patient. She wanted a VBAC so bad. With a VBAC, you can't get Pitocin. You can't augmentate them at all with Pitocin. So I had, I told her she has to go into spontaneous labor. She did not go into spontaneous labor. We were doing non-stress tests on her, making sure the fetus was okay. So on Friday, the fetus was okay. Okay, the baby was good. She was like 42 plus weeks, and baby was doing all right. But they're only good for a couple days, these tests. So I said, time is up, and I try to encourage her to have her repeat cesarean section because she wasn't dilated at all. And she wasn't going into spontaneous labor. So it didn't look like her body was working with her. Okay. So we were worried about the baby. So anyway, I went ahead and booked her in for a C-section. And my colleagues came and talked to her too. And said, if you don't go in for a C-section, my one colleague, Dr. Boone, I just love him, but he's very honest with her, said, you're jeopardizing the condition of your baby. Your baby can die. Well, that's pretty blunt to say that to somebody, right? Okay. So what happened, I booked her in and everything. Everything was good. Anesthesia was mad at me because I booked a C-section on a Saturday. You don't usually do that, okay? She did not show up. Okay. So she showed up on Sunday night. And when she showed up on Sunday night, there was no fetal heart tones. The baby had expired. So when I came on duty on Monday, I was called into the office and a whole bunch of my colleagues was there and they were there to support me because they knew how close I was to this patient. Because, you see your patients every week, and you're doing non-stress tests. You do get to know your patients. Well, guess what? I was really very upset. And so therefore, it just shows you that things run out of time. And so, yeah, she didn't have she had her baby, but he was gone. So it does happen. Remember, maternity it's very emotional. It's very emotional area of nursing. Okay, it takes a certain person to work in maternity. It's very rewarding. I loved it. I love it. But it has its downtimes. We always said this in maternity. I'll share it with you. When we're happy, we're really happy. Okay. But when we're sad, when things go wrong, we're really sad. Okay. There's no like in between. Okay. So that's why I've been going over everything with you with the risk factors, is because you want to identify the condition of your mom. You want to make sure that you get these risk factors. You want to identify problems. I want to know if her blood pressure is going to be a problem during pregnancy, because I know the increase on the heart increases. Okay, so that's what we're all about. That's what nursing is all about. Okay, all right, so I shared that story with you. All right, so everybody's good on what kind of blood tests we're going to take on that first visit. Everybody's good on Gravida and Para. Everybody's good on GTPAL, Nagel's rule, probable, presumptive, positive. Okay, all right, then I'm going to mosey on through it. All righty. Okay. So, let's see, I think I left off here. Let's go. Okay, so let me see. I think I looked at slide 30, but let me go here. Okay, so we did this. I would really make sure you have a good understanding of that. Okay. And then I went ahead and put some definitions in here for you, make it easier. So what amenorrhea is, in case you didn't know what that was, it means that she's not having a period. Okay. Nausea and vomiting is caused by what? Increase of the HCG levels in early pregnancy. Okay. Breast changes. You have tenderness, you have tingling. Okay. And these are all caused by the growth of the ductal system for preparation by the placenta. Actually, it's caused from the hormones from the placenta, which stimulates the growth of the ductal system for preparation for breastfeeding. Remember, estrogen is your stimulant. Okay. Remember we talked about estrogen, progesterone. Progesterone is needed for what? Maintaining pregnancy. Remember those slides from last week? If you don't remember them, be sure to please to go over them. Deepening pigmentation. You ever see a woman who has like a mask of pregnancy? That's called chlasma. That will go away. Linea negra is the line that goes up from the symphysis pubis up to the frontal. All the way up. It's a dark line. It starts out as a white line, like linea alba. And then because of increased estrogen, it will get darker. All right, urinary, you have frequency and urgency of urination, especially during the beginning, okay, due to hormonal changes. You have fatigue and drowsiness. That's usually a very early sign. Women go, man, I'm tired. And they don't have much energy. Okay, and then quickening. Quickening is when she feels the baby move inside. It's such a special time. Is that faint fluttering? Okay. These are the probable signs of pregnancy. I would really put this in my head. Okay, because the Goodell sign is the softening of the cervix and the vagina. Chadwick. A Chadwick, as I talked about before, is the bluish purplish discoloration of the cervix. Okay. What happens, let me tell you, the cervix is a very vascular area. Okay. So when it gets congested, okay, you see this discoloration of that cervix. And when you put the speculum in, we can take a peek and you can see it. So those are probable signs. Okay, Hager's sign is a softening of the lower uterine segment. McDonald's sign is the uterus which is flexing against the cervix. So you see all these. Braxton Hicks, so you see abdominal enlargement. Braxton Hicks contractions are irregular contractions. They don't put you into labor, okay? They're like a precursor. Ballotment, baby is bouncing. So if you want to test the baby, if it's engaged or not, you do a vaginal exam, you feel the baby's head. If you can push the head up, the baby will bounce up, go higher up in the pelvis. That means that he's unengaged. Okay. The abdominal striate is, have you seen those stretch marks on people? You know, they're stratum, striate gravidarum. And then, of course, if you got a pregnancy test that's positive, that's a pretty good probable sign. Now, your positive sign is your heartbeat. You can hear it, boom, 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 boom. You can see the baby, and you see this fetus here. An ultrasound. This is an ultrasound, and you can see the baby moving. That's pretty positive. When I shared my experience with you, that I told the young lady she was pregnant. Okay, so I put this slide in here to summarize it all, so you can take a look at it later, exactly what it is, because there'll be a question about it. So if I was to ask you, you have an antenatal client, okay, and informing the nurse of her prenatal signs and symptoms. So which of the following finding would the nurse determine is a probable sign of pregnancy?
Chadwick sign.
Good, you got it, Chadwick. So see, that's how those questions will go, okay? All right. Now, you got some normal changes in pregnancy, okay? So you got, remember we talked about the placenta is a temporary endocrine organ, okay? It produces large amount of estrogen and progesterone. Why? To maintain a pregnancy. Okay. The uterus. We talked about the uterus already. It's a pear-shaped organ. It grows. When it's usually tucked down in the pelvis, you know, out of the way. But when there's a baby been conceived, as the fetus grows inside, it will move that uterus up out of the pelvis and becomes an abdominal organ. It's a temporary abdominal organ because it doesn't stay that big all the time. Okay. And because you got the baby, you got placenta and amniotic fluid, it can get pretty, the capacity is pretty good, about 5,000 mLs. It can house a lot, okay? Respiratory. You ever see a pregnant woman try to climb up the stairs, especially as she gets to be in the second, third trimester? It's because she has decrease in oxygen consumption, okay? She gets short of breath. She can't run up those stairs anymore. Okay, another problem is the cardiovascular system. Changes, big changes. That's why I want to know that baseline. I want to know her blood pressure when she comes in. I want to know her pulse rate. I want to know what she is in the beginning, because the pulse rate increases about 10 to 15 beats per minute. She has increased blood volume, cardiac output. It increases about 45%. The heart is going to have extra work, okay? This is where these women that come in and they have some cardiac problems, cardiac complications. Maybe they were premature when, you know, they were first born, and now they're coming in, and these women are having babies, and there's an increase of cardiac problems. We deal with them, okay? Women can go in congestive heart failure, okay? It's because the heart has to pump out more. All right. Now, gastrointestinal, just remember, okay, with your landmarks, you know, your stomach, okay? The uterus grows, right? It pushes all the organs, guys, up higher in one. So the stomach now, she used to be able to eat a whole bunch at one time. Oh yeah, I'm good. She gets into her second, third trimester, especially third. The stomach now is pushed up because the uterus is now higher. And now she has to eat small, frequent meals, okay? She still has to get her nutrients, but she can't eat those big meals anymore because she gets heartburn. A lot of ladies get heartburn or esophageal reflux is because of how the uterus is growing up inside. Urinary system. Remember, the system excretes waste products for both the mother and the fetus during pregnancy. Sure, she's going to go what? To the bathroom. All right. I talked about a little bit about straight A's or the stretch marks. The skin has great amount of elasticity to it, okay? But when you gain weight fast, all right, then the skin has to grow. And the skin doesn't keep growing, right? It has these like marks, you know, you can see those marks, those straight A gravidera, we call them. And there was a stretch. The skin had a stretch beyond what it should have been. So they don't go away. They do fade over time. And it takes a long time. And when they fade, they'll turn into like a silvery looking straight A. Okay, but they never really go away. We always want to worry about balance in a woman because she has this growing tummy. Okay, that throws off her gait, you know. So you ever see like women waddling, you know? I mean, I know when I was pregnant, I had some big babies. I did some waddling. It's because I had all this weight here and I had to balance everything. All right. So, and also the pelvis gives too. So you have the joints that are more relaxed. And so they also cause that waddling gait. I'm also worried about women with high heels in their third trimester because their balance is off. If you got this big old belly and you're trying to wear these high heels, you're going to have a balance problem. So I don't always tell my patients, let's lower the heel. Okay. I love to be in sneakers or low flats is because you have a better balance. What am I worried about balance? What am I worried about? I'm worried about
Mom falling?
Yeah. Pregnant women can fall quite a bit. So got to make sure that they're safe. Okay. Because when they fall, I'll tell you what, we worry about it is because if the woman falls, she can dislodge the placenta, can abrupt right off that endometrium. And then you have a condition called placenta abruptio placentae, and that is an emergency. That's an essential emergency. And so I do not want her to fall, okay? Because that she needs to be delivered very quickly when she has a placenta abruptio. All right. We talked about the endocrine system. So you can go over these. I made some really nice slides for you, and you can see what happens. Basically, you have all your hormones that affect all the body systems during pregnancy. All right. And I talked about the placenta being a temporary endocrine organ. So we're gonna skip over that and we're gonna go to the next one. I talked about this already. See, I added some slides for you because I know they're important. And I did some highlighting here for you because I know it's important. So what I want you to get out of this one is not only it gets quite big. This is what you're looking at, the fetus, placenta, amniotic fluid. We talked about a temporary abdominal organ, that's your uterus, the cervix. The cervix is really important that it stays thick and long, okay? As she gets closer to term, the cervix starts to get shorter because now we're getting closer to term. The body knows that we're going to probably go into labor soon. The mucus plug, I pointed that out last week when we did the schematic drawing of the cervix. The mucus plug is there for a reason. It's to keep out bacteria. And it does a good job because, like I said, all bacteria ascends up into the uterus. Okay, I don't want her to get chorioamnionitis. I don't want that chorion, the amnion, to get infected because when that gets infected, it affects the fetus. Okay. And then we talked about ovaries already. You need progesterone to maintain what we call the decidua, which is your the uterine lining or the endometrium, okay? And that's really important because that sustains everything the very beginning, like 6 to 7 weeks into the pregnancy. And then after that, the placenta will take over that role. Okay. All right. I'll let you, again, this is on the vagina and the breast. We talked about on the breast, they have high levels of estrogen and progesterone. It's all to prepare the breast for lactation. You have the tubules of Montgomery. They secrete a substance to lubricate the nipples. Okay. And then you have your colostrum. We'll talk about that when we get into newborn. All right. So this is what I wanted to show you the picture of. This is a practitioner doing a fundal measurement, fundal height. So you can see here where he puts one part of this is a measuring tape in centimeters. And so he has here his fingers on the bottom, which is on her symphysis pubis, comes up the center of her abdomen. That'd be the linea negra he's following, comes up to the fundus. Fundus of the uterus. We talked about that, remember? And so we're measuring. If he's measuring her to be, this one looks quite along here. So if she's 40 weeks, how many centimeters should she be?
40.
40. Okay. And we really use this quite a bit. So what I want you to show you, the picture on here, is here is your symphysis pubis. Let me get my little marker. And you can see how, like here at 9 weeks, she's down here. And then she gets about 10, here's 12. It becomes, the uterus comes out of the pelvis. And now this is 20 weeks. 20 weeks is at the umbilicus. Just write that down. 20 weeks is at the level of the umbilicus. And then here you can see how the baby's growing. You got the lightning, and then you have here, you see the ribs. And the ribs, they all kind of stretch out, okay? You can see why they would do that is because they had to accommodate this growing uterus. We use this a lot to determine if there's if the baby has what we call, it's an IUGR, which means it's an intrauterine growth restricted baby, okay? We want to pick up these things early, because we can make sure we have the proper delivery for her and make sure we have the proper resuscitating efforts, and maybe look up, do an ultrasound on her, look up the amount of amniotic fluid that's in there, okay? We want to make sure there's adequate still in there for baby to grow. Remember, the function of an amniotic fluid is important, because you have to have amniotic fluid for that baby to grow, and to grow what? Symmetrically, okay? We talked about that last week. So that's why we want to make sure there's enough fluid. When the fluid level decreases, especially as you get closer to term and post-term, that level can go down. That could harm the baby. So we don't want that to happen. So amniotic fluid really protects that fetus. Okay, respiratory. Like I said, oxygen consumption increases by 15%. The diaphragm, the diaphragm rises about 1.6 inches. It caused the ribs to flare, like I said. So yeah, you can. Now, a lot of times women have problems breathing during pregnancy, okay? Because it's so high up, we just tell them to take rest periods, put the legs up. If they're climbing stairs, stop in between. You can't walk the flight of stairs like you're used to, because we don't want them to get dizzy, lightheaded, and fall. Okay. Now, as the fetus, though, descends, goes into his head goes lower and lower, then guess what? She can breathe again. So a woman will come in and say, I can breathe a lot easier. we do a fast check and we can find where the station of the head is and say, oh yeah, that baby has descend. Baby's head now is at a 0 station. And so now I can see. So she can breathe. All the ladies like that. A lot of ladies complain of nasal stuffiness and the voice changes. That's all because of estrogen. Okay. Estrogen again stimulates the swelling of the mucous membranes of the nose, pharynx, mouth, and trachea. Okay. So I guess you can see by now how these hormones affect a pregnancy. All right. I told you before, blood volume increases about 45%. Some books say 45 to 50. Definitely is an increase in cardiac output. So, reason why, I think you probably now figure out why you would have to have this, right? Because the baby, because she has to supply all this to the baby, she needs to have more of herself. It's like, okay, I got double duty here. All right. So the body makes more. All right. So you have exchange of nutrients, oxygen, and the waste. Now remember, the placenta is all, that's the functioning of the placenta. But again, where does it come from? Mom. All right. So also at birth, when she gives birth, I know you've probably seen birth either on television or maybe at the hospital, but there's a lot of blood involved. Okay, there's a lot. The uterus has the blood supply. Remember, I told you the very vascular area. She can bleed very easily. She loses a lot of blood at birth. Okay, all right. By having an increase in cardiac output by like 45%, she's able to accommodate that. All right. Now that's why we worry about anemia during pregnancy, is because if she's low, then that's not good for her or the baby. And definitely at birth, we have to be careful of how much she loses, because why? Because she'll be very anemic. All right. We don't want that. And her pulse does increase during pregnancy, like 10 to 15 beats. I've got to monitor that when she comes in. So that's why when the baseline vital sign, so important. Okay. All righty. Let's go here. Let's talk about this supine hypotension syndrome. You'll see it again. So heads up, write it down, whatever you do, you'll see it again. What happens if you lay a pregnant woman on her back? Let me show you. I think I've got a diagram right here. If you lay her pregnant woman on her back, can you see how the pressure, remember I said you can have 5,000 mLs with the fetus, placenta, and amniotic fluid. You see how much pressure can be put on her vena cava, okay? So her blood pressure, what? Goes significantly down, okay? She can bottom out. She can have hypotension. She can be dizzy, lightheaded. She's not feeling well. You never lay, write that down. You never lay a pregnant woman on her back. She's never put into a supine position. Now you may say, well, how about a C-section? Are they not in supine? No, what we do, we get her over the table and we put her on a left lateral tilt. Okay, we still got her on the OR table, but now she's on a tilt. She's not on her back. Okay, because we don't want that to happen. Exactly. Okay. And then two, if she's having contractions, just say you have a woman in labor, right? Okay. If she has contractions, now a good contraction is equal to 50 millimeters of mercury. That's a lot of pressure. So imagine if you have her on her back and she's having contractions and you have 5,000 mLs of fluid in this uterus. Imagine she's not going to be able to breathe. All right. She's going to get really lightheaded on you. All right. So you don't want to labor her on her back. Okay. Okay. I think I made my point. So what are you going to do? Put her on her side. All right. Put her on her side. Now, I say left side. Book says left side is because you get more placenta perfusion. You get better blood perfusion when she's on her left side. So put a lady on her side. And look at here. I think this is really nice. This is a pregnancy pillow right here. Very comfortable. All right. All right. So let's move on. We talked about this already, so I'm gonna skip over that right now. How about the GI? GI, I talked about that already. Appetite, thirst may all increase. They want to eat. Make sure that she's eating nutrition. Okay. Now, because of progesterone and estrogen, it relaxes the muscle of the gallbladder, the toneness, the muscle tone. She's tends to more retain bile salts in the gallbladder. So you can have itching. Ever seen a pregnant woman itch a lot? Okay, it could be the gallbladder. We've had to take out gallbladders during pregnancy. We do it. It's risky. It is, but we have to do it sometimes. And L&D nurses go to the main OR so that we can monitor the baby during the surgery. Okay. All right. And we just remember everything displaces that growing uterus. It displaces the stomach and the intestines. All right. This just shows you what happens during pregnancy, and you can now, later on, you can really look at this and see how the growing fetus affects the other organs in her body. Okay, the other organs in her body is significant. All right, now you're probably thinking, we talked a lot about UTIs. You're probably thinking, what actually causes that? Well, I put it in here for you is progesterone that causes the renal pelvis and the ureters to lose tone. So remember, we have to have estrogen, you have to have progesterone, but when you get a loss of tone in the uterus, you don't put out the urine, so you get a buildup. So then you have this urinary stasis. When things lay in there and they're not excreted, that bacteria grows. Now, this is for pregnancy and for a regular med-surg patient. That's why you want to make sure that a person has at least 30 mLs, right? Med-surg patients at least 30 mLs per hour for urinary output. Is you don't want to have urinary stasis because then they can lead to a UTI. Okay. We talked about striae. We talked about, well, how about spider nevi? Those are those little veins in the legs you can see. Postural changes. A woman's back she can have a lot of backaches during pregnancy because she gets what we call lordosis. That's that curvature in the back. You know, she's walking like this, and she, later on curve your spine a little bit and you can feel it. That is because of the growing uterus. Okay, we talked about waddling gait already, and we talked about the change in the center of gravity. High heels, not good when you're pregnant. All righty, talk about safety alert already. Lactation. We always say breastfeeding is the best. Okay, remember this, breast is the best. All right. And so we would just educate for women, you get 300 more calories during pregnancy and 500 more when they're breastfeeding. I usually try to talk my patients into breastfeeding. I said, well, you get more calories. And my young patients, I tell them they can get into their skinny jeans a lot sooner because the uterus involutes a lot faster when you're breastfeeding. All right. Let's go here. You always want to educate patients on reading food labels. Med-surg patients, any kind of patient, they need to know what they're eating. And the government mandates that the identification of like how much sugar is in everything, how much sodium is in everything, so that people are well versed on what they need to have. So this is really important to know. You should probably see this on exam 1. Weight gain. So a normal woman of normal height, okay, can gain anywhere from 25 to 35 pounds. Okay, that's the normal. Now, overweight women that already come in and they're overweight, then you have to taper that down a little bit, and they can gain from 11 to 25 pounds. Okay. Now that's tough. It really is tough. And then the obese woman can gain anywhere from 11 to 15 pounds. Now that's really tough too. And that's why those women really need to know about nutrition. Again, everything gets a little more complicated when you have a little bit more extra on you. Okay, so I would know that. I talked about the calories already, but I did put in here how much protein, like 60 grams per day, calcium 1200 milligrams per day, iron 30 milligrams. Okay, and of course your folic acid, at least 400 micrograms or 0.4 milligrams a day. All right. Now, pica is a craving in pregnancy for non-food items. Non-food. That means they crave like starch, or they crave like what else they crave? Soil. They do. And you may think Joe may be sitting there going, that's crazy. Who would crave soil? Yes, it's just special nutrition considerations. Some people like chalk. Yep, chalk. It's normal. Now, what a nurse has to be aware of is how much are you having of that. So say you had a question about the non-food items and oh, that's pica. Okay. The nurse has to ask the patient, okay, how much of that chalk are you taking in? It's not like not like you would answer, go, oh, you shouldn't eat that. Well, that's a non-food item. Knowing that that's a normal thing that happens in pregnancy, you accept that, but you want to know how much of that she wants. Okay. I had a friend that ate soil, okay, during pregnancy. I was a little concerned, okay, but she had a little area in her garden in the back, and she had the soil back there. I was just concerned of how much of that she was taking in. Okay, you got to be, that's how you have to be sensitive, because those are things that can happen during pregnancy. And during lactation, I already went over. This is a good slide to keep and refer to when we get into newborn. But again, they get 500 calories more a day because of lactation. Okay. Okay. Remember something too. Anything a mother takes in, and now she says she's delivered. Okay. Anything she takes in and she's breastfeeding will go to the breast. So if she eats like too much chocolate, the baby's going to have loose stools because a lot of that substance would go right to the breast. Any drugs some mom takes in will go to the breast. That's why women that are HIV positive do not breastfeed. Okay. Another thing I want to go over with you and make sure you understand is exercise during pregnancy. So take a deep breath. We're almost finished. We tell them to be very careful. If you weren't doing like running before you got pregnant, you're not going to start a new exercise during pregnancy. Okay. Walking is a good exercise. If you live in Florida where it's really warm, you want to walk early in the morning or in the evening. It's just what I highlighted here for you to take from this is just maintenance of fitness. Okay. And I know that when women are out there walking and they do good during the pregnancy, they come in and they're able to tolerate the labor much better, and their muscles are strong. So when they have to push, their muscles are more effective at the pushing. So it does work wonderful. We do want them to get out there and walk. But just to be careful, if you didn't do a marathon before, you're not going to do a marathon during pregnancy. I had women that came in and said, can I run a marathon? And I'm saying, did you run before, she got pregnant? No, I just thought now I'm going to do it. I just had this tendency and said, no, you're not going to do it now because she's not used to it. Her body's not used to it. You have to be careful that her temperature doesn't exceed 100.4. So you want to make sure, because when mom runs a temperature, it can impact the circulation to the fetus and then decrease the cardiac function. So we don't want that to happen. We don't want mom to have decreased cardiac function because that will help harm the baby and decrease the blood supply to the baby. We don't want mom to get hypotensive, just like we talked about that's supine hypotension syndrome. We don't want her to get hypotensive because of why? It reduces the blood flow to the fetus. Baby needs blood because blood has oxygen in it. So again, we got to keep baby good. Cardiac output. As long as sometimes you have the peripherals and they'll pulling, so you see like swelling, and that decreases the cardiac reserve for exercise, because remember, she's got a 45 to 50% cardiac increase in cardiac output. So just moderate exercise has a lot of good benefits, makes them feel good about themselves. Again, it cuts down on the musculoskeletal discomforts that she has during pregnancy. And also, it does help them after they deliver to go back to their pre-pregnancy weight. And that's what breastfeeding helps too. With the involution process, where the uterus will involute or decrease after she has a baby, will decrease, okay, like 1 to 2 centimeters a day, so that basically she goes back into her skinny jeans. That's how I get the young people to breastfeed. Okay. All right. So back to travel. This is an important one because you'll probably see this again. Traveling by plane is okay until she gets about 36 weeks. Now, because then, she's got to stay put, because you don't want her to be sitting for a long time. Even when she's, traveling and she's like 20 weeks, you get up and move, because the risk to a clot is very much more exaggerated during pregnancy. So we want to avoid sitting for a period of time, avoid locations that would expose mom to infectious diseases. Not good. Okay. You don't want to go into a country that maybe they're having an outbreak, or you get an infection, then your fetus can get infected, and then you got problems. We usually tell them to hydrate before getting on the plane, and then also keep yourself hydrated while on the plane. Get up and walk around. Don't sit the whole time on the plane. And of course, once you get to be 36 weeks, that's it. Because you don't want to be going into preterm labor in a strange environment. And even though we have computers now, we always give a copy of the obstetrical records to the woman traveling. The reason why is you want, wherever you go, say you live in Florida and you're going to go to New York for the weekend, you want to make sure that in case anything happens while being in New York, that you have your obstetrical records so you can go to the hospital and say, this is exactly what I've already had done. Okay. If you don't have it with you, then they're not going to take your word that you had all these tests. They want to see what you had. So therefore, bring your records. Now you'll probably see the question on that. All right. Again, these are everything we'd already talked about. We talked about fatigue, nasal stuffiness, nausea, heartburn, constipation, hemorrhoids. Hemorrhoids do occur. They're varicosities in the anal area. They're very much, a lot of women get them during pregnancies because the increase. Remember, I said there's like 5,000 mLs of fluid, placenta, and fetus. There's a lot of pressure, okay? And then she gets a little constipated, and then you got a problem. Because then, the weakening happens, and then you have these beautiful hemorrhoids that show up, okay? They hurt. They hurt, and they hurt during labor. And then when you're pushing the baby out and you got hemorrhoids, it does cause a lot of discomfort. Okay. All right, let's move along here. Pregnancy is a special time in a woman's life. Pregnancy can be a time of happiness and a time of stress. Remember I said in the beginning of the pregnancy, there could be a lot of different feelings about ambivalence and all that. And, we have like special people such as Reba Rubin, who really looks into the psychosocial aspect of the woman. You want to manage all these different psychosocial problems because you want to have a positive outcome, okay? We talked about nutrition, and then of course pregnancy, time of stress. Not only for the mom, but for the daddy involved, the partner, and the family. Okay, we talked about that. All right. So here you have Reba Rubin. She had 4 maternal tasks that the woman accomplishes during pregnancy. She's a really neat lady. She was the first specialist in maternity nursing, goes way back. She not only saw pregnancy and concentrated on the mom, but also the psychological, not only the physiological, but her psychological. So first she said it's breaking down to 4 tasks that a woman has to go through. First, she sees the safe passage for herself and her fetus. And remember, a woman has to give birth. So she got to understand the safe passage. So that's what our role too is nursing, maternal newborn nursing, nursing is all about, is that we let her know about the safe passage so she can visualize it. Secure and acceptance of herself as a mother and her fetus. A lot of ladies don't see themselves in the very beginning as a mom. They have to learn to accept that. And again, nurses help with that. Learning to give of self and to receive the care and concern of others. Okay. And then committing herself to the child as she progresses through the pregnancy. Not only does mom have problems, but daddies too have a certain role. And here, this is called the different developmental stages of fatherhood. You have announcement, whether pregnancy is confirmed. Okay, remember, going back to the first one, ambivalence. Maybe daddy is going, oh no, okay. Then they have to accept that. By accepting it, it strengthens the family unit. Then they go through, the daddy goes through an adjustment period. He had, that adjustment period, you're making plans for the future. And then you go by the next one, the last one is focus. Now I'm going to focus on the pregnancy. I'm going to focus on my beautiful wife or my girlfriend, whatever it is. And now I'm going to I'm going to participate in the labor. I'm going to be there for her in the birth process. That's the focus. And daddies go through that. And there's also 3 P's of fatherhood. The 3 P's are provide, protect, and be there. Be present in the pregnancy. And you'd be surprised, we don't have that all the time. Now, make sure that you understand those different phases, okay? Because they are important, and you might see a question about that, where the question will describe what's going on, and then you have to pick out which one of it is. That's why I went over it for you. Cultures, different cultures vary. It's just that you have to be aware of the different cultures. Some daddies look like they're not even interested. I've had daddies where they were in the delivery room, but their back was to the woman. There were no support whatsoever. So then you have the nurse that gives the main support, or you have a doula in the room, and she gives the patient, she's an advocate for the patient and gives the patient support when maybe the husband, due to, not because he's not interested, but because of their culture, that he might not be participating like, you would normally see. Okay, it just varies. So it's something to think about later. Has the role of the father changed over the past decades? And that you can answer yourself. I think has. I've seen a lot of changes. My daddy's in the room. I've had daddies want to be in that room so badly that they'll do whatever. I go back to the 1980s where, um, we didn't have daddies always in the room, okay, and they would cry when they wouldn't want to get in there, okay. So that has changed over the time, but you can probably read about that more. At adolescent, this is a very a heartfelt area for me because I labored a lot of adolescents. They go through a lot. They have to go through this transition. Don't forget, they're developing. They're not, some of them are really young. I mean, I labored a young 13-year-old. Remember I told you, you get pregnant before you even had your first period. And it's heartbreaking because their bones, remember how the bones open up, the ribs and the pelvis, and they go through a lot, okay? And their support system may not be so good, okay? They feel alone a lot of times, and they try to hide it. This is like from Time Magazine here. It was an article, Children Having Children. They hide it. They don't eat right because they don't want to gain a lot of weight. They're going to wear baggy clothes. They try to hide as long as they can. Some young girls deliver out on the streets. And then now, thank goodness, we have safe havens. Safe haven is in a firehouse, okay? And that's what it looks like. It looks like, how, I'm not trying to think. It's like you open up the door and you can put the baby in and then close the door, and the buzzer goes off in the fire department to tell the firefighters that someone put a baby in there. Okay. So at least we have that. That's wonderful. It's called Safe Haven if you want to look that up more. It gives the teenager, the adolescent's place to put a baby if she doesn't want the baby. Okay. It's better than putting it into a bag and putting in the dumpster. Okay. Because that has occurred over the past, over several years. And so at least that's better. Okay. Just remember, adolescence is a time where they do feel alone and they don't have the support. And maybe in the beginning, there's a lot of problems going on with the father of the baby and his family. There's a lot of, very much so, of not good dynamics in this family. So if I was to ask you, what would be the first priority in working with the pregnant adolescent? Which one would you think it would be? You always want to assess their attitude toward pregnancy. You might see this question again. So you maybe say, well, how about substance abuse? It's my first priority in working with a pregnant adolescent is assess for attitude toward pregnancy. Okay. And then you can work on other problems. Older couple, I talked about that earlier. They're usually more the opposite of an adolescent. They're more in tune with their bodies. They're going to eat right. They're going to come to preconception counseling. They have their careers and they're kind of settled in their ways. That also, even though it's good, settled in their ways can make it hard for them to adjust when they do have babies because they're used to their independence. And when you have a baby, your independence is gone. Okay, and that was this. They do have what we call unique concerns. All righty. I think I'm coming to an end now. This talks about the older after age 35 pregnancy. They will be classified as a high-risk pregnancy. Listen up, high-risk pregnancy. And so they may have to have extra tests. One I'm thinking about is the amniocentesis. We do an amniocentesis at the beginning of pregnancy in order to get chromosomal analysis. Okay, we have to look at the chromosomes to make sure if we have they all paired up nicely. If there's one that has an extra tail to it, trisomy, that's indication of Down syndrome. So they have more challenges. They are high risk. You have to watch them a little bit more. So yes, they do have their challenges. The adolescent or the single mom. Single mom could be a woman on her own. She either adolescent or mature. They have unique emotional needs. Can you see now how maternity is very much of not only physical, but emotional side too? And so a single mom, she has to worry about lifestyle changes. She has to worry about when this baby's born, who's going to take care of it while she's working? A lot of problems go on, and that happen. We deal with those in pregnancy. Okay. So I went ahead and put some slides in here of a single mom and what they have to go through. Not easy. Single daddies. Don't know you guys. Oh, Joe and Kirk, I included you. They also have their time they have to go through, like we talked about. They have to worry about finances and take responsibility for the child after, and what's going to happen after the baby is born. Okay, same thing. How about grandparents? They're kind of eager about everything. Just depends. Now, I did put it here because I wanted to give you the nursing process that used for maternity. So, and this goes over like prenatal education. So, like, we're going to assess the history and cultural needs of the patient. You diagnose the knowledge deficits. That's always a great nursing diagnosis, by the way. Plan your goals and priorities for this patient. Know what she's beginning her baseline. Know the changes that can occur during pregnancy according to the week's gestation. And you can plan her whole pregnancy out. Teach what she needs to know. And then, of course, you're going to always evaluate. Did we reach our goals? Did we do it? This goes over, I already went over this with lactation and medication, so you can look at that. And I think we're coming to an end because I'm running out of time. Don't forget, you read the chapter. I put on here, be sure to read pages 78 to 81 is a summary. I love summaries. And don't forget, I hope that you are all doing this unfolding case study. It's in your book. You follow the husband, Lewis, with his wife, Tess, and you answer the questions. If you cannot answer those 5 questions, you need to go back and reread that chapter because you're missing the heart of the chapter. Okay? So be sure to take note to that. All righty, it's now 5:30. I'm going to let you all go. That was a lot of information. Thank you for staying. I will be doing your attendance. And if you need me, I'm here. I do a weekly review tomorrow. It's not as long. It's only like an hour long the most. And it just goes over the highlights. Okay. Take care, everybody. Read. Did I say that enough? Bye. You're welcome. It's my pleasure to meet you, to teach
Thank
you
you.
today. You're welcome. Bye-bye.
Bye.
Bye. You're welcome. You're welcome. Bye, everybody.